Hey, Paul, my sister was crying, so I asked her if she was having a crisis. No good?
No.
Crisis? Crisis?
No, listen, I got the joke. It's not good.
All right, Paul, what do you got?
Nothing.
All right.
No, I'm sorry. Just judgment for you.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Franquato, here with my great friend and America's primary care physician, probably the primary care physician, Dr. Paul Nelson Williams.
Trademark, copywritten. No one else try and take it. Hi, Matt. How are you?
I'm doing well, Paul. This is an episode with a returning guest, Dr. Jessi Gold. We're talking about depression. We even talk about treatment-resistant depression. And it's a fantastic episode. Paul, before we tell everyone about our great guest and our co-host for this episode, what is it that we do on Curbsiders?
Sure. Great question, Matt. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. As you alluded to, we are joined by an additional co-host tonight. This is also the producer of this incredible episode. We are joined by Zoya Sarani, a second-year medical student who put together an incredible episode on, was this Depression 301 are we at now, Matt? But we're
Probably.
Yeah. Another round of depression, which I feel like I can never learn enough about this. But Zoya, so nice to see you. How are you?
I'm doing great. Thank you so much for having me here. And I'll just go ahead and share a little bit about our episode and also about our guest. So, as we mentioned, we have a returning guest, Dr. Jessi Gold, who you might recognize from our incredible episode on anxiety, which is episode 429, titled Anxiety 2.0, if you're looking for that. And Dr. Gold is the Chief Wellness Officer of the University of Tennessee System and an Associate Professor in the Department of Psychiatry at the University of Tennessee Health Science Center. In her clinical practice, she sees healthcare workers, trainees, and young adults in college. Dr. Gold is also a fierce mental health advocate and highly sought-after expert in the media on everything from burnout to celebrity self-disclosure. She's written widely for the popular press, including for the New York Times, The Atlantic, InStyle, Slate, and Self. Her first book, How Do You Feel? One Doctor's Search for Humanity in Medicine, came out just recently in October 2024 from Simon Element and is already a national bestseller. Dr. Gold is a graduate of the University of Pennsylvania with a BA and MS in anthropology, the Yale School of Medicine, and Stanford University Department of Psychiatry, where she served as chief resident. And today she'll be talking about how to approach depression diagnoses and management, how to choose the best antidepressant, and when to turn the alternative treatment options like ketamine, ECT, and psilocybin. So, without further ado, let's get to it.
A reminder that this and most episodes will be available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. Jessi, the audience has heard your bio. They know your book's available, but now we need to know, you've written the book, so like what hobby or interest are you now pursuing, and preferably one outside of medicine?
Yeah, I'm working on that because I think that's just a thing we're not good at in medicine. I have been trying to read more. I had my bosses recommend books like on things like leadership that I know nothing about, and I've been trying to read that. That's still work. I think when I'm doing nothing, it's television. I watch a ton of stupid TV.
When you said read more, I just had to think of like, Paul, that's like every evaluation that she ever had that was like, she's doing a great job, just read more.
She needs to read more.
She's finally getting to that.
The weird thing is like, I used to not like learn, like I think medicine made me stop liking to learn sometimes, and like learning an entirely new set of things that I don't know anything about has reminded me I like learning, which is maybe weird and maybe dorky, but it is true.
That's the purpose the show serves for me. Like I find real joy in that. And then once I'm done with the show, I have no desire to read nonfiction or Harvard Business Review or leadership and thoughts on courage and bravery in the workplace. Like I'm glad that it's out there, but I don't have it in me. I'm exhausted at this point.
Zoya, anything you want to ask?
Yeah, so kind of on that topic, if you weren't in medicine, what would you be doing right now?
I probably would be doing some kind of advocacy, like whether that's working for a nonprofit or working in policy. It's a very complicated thing to be interested in these days, but I think that is something that I've always liked and enjoyed and wanted to learn more about, and gives me meaning and purpose within the context of work too. So I think that's where I would end up.
Paul, anything else before we get on to the cases?
I like this final question that Zoya has provided. So I am going to ask, where is your happy place, Dr. Gold? I think it can be either emotionally or an actual physical location. I just like how broad this question can be. So take it wherever you'd like.
Yeah, I mean, I like a beach somewhere with waves crashing. That's usually a happy place. It doesn't matter where the beach is. I grew up in Florida, so I like beaches, but I think that is a happy place. And the more boring answer might be with my friends and family, whoever that is and wherever that is.
My mind, Paul, immediately went to Happy Gilmore, the cutscenes.
Yeah. That's your happy place with like the pouring milk, like beer and the money
No, I mean
coming
just
out of
serving my grandmother a glass of lemonade or whatever happens there.
Yeah, aboard, Matt.
Chubb's having his hand back. It's what you think about all the time.
All right, I think we should get to a case. Zoya, would you start us off?
Absolutely. So, on the topic of happy places, we're going to be talking about depression today, and always good to remember what makes you happy. But we're going to be talking more about the management today. So, for today's show, we're going to have two patients. They're both coming into their PCP with symptoms of depression, but I'd love for us to discuss the differing approaches for the two patients, and also if and when referring to a psychiatrist is recommended. So first off, we have Miss Down. She's a 26-year-old female with past medical history of obesity, hypothyroidism on levothyroxine, and obstructive sleep apnea. She uses her CPAP inconsistently. She also takes oral contraceptives, and she's presenting to your office as a new patient. She recently moved here to the area for graduate school and complains of about 3 months of feeling down with low energy, having difficulty sleeping and concentrating, has decreased appetite, and describes not being interested in anything. She shares she has had periods where she feels down previously, but they're normally related to her menstrual cycle and last at most 1 week. She doesn't really know why she's feeling so down and why it's been going on for so long. So for Miss Down, our first question is, what elements for her history stick out most to you? I know there's a lot going on, but what next steps would you take? And are there any labs or studies that you would want to run?
When you read the case, when I read the case, it's hard to not feel like those, like literally everything stands out. I think it's important to recognize that depression is, and all mental illnesses are diagnoses of exclusion, meaning you need to rule out the medical causes. If you have a history of depression, it's going to put those medical causes still important, but maybe you're also thinking them in parallel more. If you've never been diagnosed before, you're 100% going to rule out like absolutely everything before you think about depression just because you don't want to miss something medical. Often that's because some of the medical things can be corrected faster, and that is important, but also because it's a different treatment. So when you read that, hypothyroidism is related to depression, very similar symptoms. The patient's on medication, so it's possible it's already treated, but if it's undertreated or the patient's not taking the medication regularly, you could have more symptoms that look like depression. If you look at sleep apnea, that's also correlated with depression because you're not sleeping and you feel miserable, and fatigue and not sleeping are also depression symptoms. And so making sure people wear their masks like regularly, making sure that they're actually using their machine, things like that are questions you're going to want to ask as a result. She also mentions being on birth control pills and having a lot of things correlate with her period. I think that's very important to look at as a cause, because we have a different diagnosis than sort of major depression, which is called premenstrual dysphoric disorder. And that is more related to your cycle and has more irritability. And the rest of the symptoms can kind of look the same, except you get some different physical symptoms. But, it used to be called PMS, and then they put it in the DSM as PMDD. So that's something to think about. And birth control pills can be related themselves to causing depression, sometimes in people and younger people especially. So that's important to bring up as well. What I would probably do is get more history. A lot of that could be answered with conversation, digging more deeply into what the cycles look like, digging more deeply into timeline and her history, understanding if she's ever had some of the symptoms as a result of the medical things before, family history, things like that, also important. But then at the same time, I would get basic labs. So thyroid, CBC, like B12, because that can make you sad. Iron makes you tired. Like anything you would normally do for a fatigue workup, or would do like in a patient where you're hoping it's a vitamin deficiency and you can just give them a med and it's better. That's what you should do.
Yeah, people always ask me about vitamin D as well. I mean, I have a low threshold to check vitamin D or to tell someone, yeah, sure, take vitamin D because it's just so safe.
Yeah.
But I'm not convinced that I've ever cured depression by replacing vitamin D, but people do seem to like to take it.
Yeah, and we test for it in that sort of panel of things too, just to make sure, again, if it's winter and you haven't been outside and you have an indoor job, any of those things could be you're not getting enough sunlight. And of course it can relate because basically vitamin D is on the pathway to making serotonin. That's why sunlight helps too. But it's not going to be like the be all end all for somebody with that many symptoms, probably.
Yeah. Yeah, and we talked recently on an episode about the non-anemic symptoms of iron deficiency. So low threshold to send a ferritin, even if the hemoglobin looks normal, they could still have iron deficiency, and that you could treat and see if they feel better from that.
Yeah, I think timeline's important in this in general, just because it has been going on long enough to consider depression too in there. And also she just moved, and that's important in terms of like social related reasons why someone might be sad. Like if you move and lose your support system, or you don't have a job yet, or you don't know where even to go, and this is like your first establishing care to talk to a human about what's going on. I think that is something to pay attention to as well.
Does that train? I guess this is a very specific question, and this might not be the place to ask it, but that never stopped me before. But like, I guess, what do you do with like, how important is chronicity, and then an exacerbating factor? Like, because I feel like you see that a lot. Like someone who's had symptoms like this patient that feel very sort of depression-y, and then have a recent sort of life event that actually, feels almost more like either grief or adjustment. Like, I guess how do you factor those things in, and how do you tease out what is depression and what is other extenuating circumstances? And I don't know that may not be a fair question to ask.
No, it's not a fair question, right? So when somebody comes in for me, I want to know why now. So even if you are sad and have been sad on and off, or have been sad on and off with your period on and off, like understanding what's going on right now that leads to it is important, especially from a supportive psychotherapy, other intervention perspective. And then, major depression's timeline is 2 weeks at least. I think that I also would look at severity of symptoms, how much they're interfering with your day-to-day life. And so a lot of times in my patients, that's like just work. And so you want to understand what the rest of their life looks like too, and that they're not just like isolating, drinking all the time, eating all the time, not talking to anyone, and then going to work and doing just fine, So you want to check in on that stuff too. But, all psychiatric illnesses at the bottom of like the DSM says something like how much does it impact their life? How long has it been going on? And what's the severity? And I often think those are the most important questions, because you might have even done a screen up front of symptoms anyway. And so it's not really like, you're not going to even ask much more probably about the symptoms, except for like just trying to pin details down. And so understanding those things can really help you understand if it's like she's having a bad day or a bad week, or she maybe could be having something more going on.
Yeah. Someone just came off like 2 weeks of nights or a month of nights. And then you're like, I want to quit residency. You're like, maybe just wait like a week, let your,
Yeah, I have a lot of patients that sometimes it has to do with the rotation, like in med school or residency, right? They're just like, I don't think I like this rotation. Can we check back in 2 weeks? And that's fair. A lot of the symptoms like sleep, eating, fatigue, that could all be just like, schedule changes and stuff like that. So it is important to be mindful of that.
All right. So wait, let's get to the next part of the case.
Yeah. So I think just like what you recommended, she got a lot of labs, and her BMP, her thyroid, her CBC, her vitamin B12, vitamin D as well, and all of her iron studies came back looking normal. And so she also started making some lifestyle changes. So she's using her CPAP regularly every night. She's seeing a therapist at her school, and also returns to her clinic 1 month later, feeling much better. But she asks you what to look out for and what to do if she starts to feel worse again. And she also shares that her family isn't really receptive to the idea of depression, and they don't really understand or aren't very supportive of mental health care. So what would be your spiel, or how do you explain depression to a patient or a family, particularly when they might not believe in depression or depression treatment?
Yeah, there's a lot of people that's the case. They think you can kind of pick yourself up by your bootstraps and it's not a big deal. I think the image of depression isn't always what severe depression looks like. It's often like, oh, you're just so sad. Get up. Like, what's wrong with you? Go for a run. And that's not helpful, but I hear it a lot from patients about their parents, and that can be pretty common. As much as patients might not agree with what their parents' opinions are, it can impact their ability to want to take treatment or even have effective treatment, because if they don't believe it's going to work, I think there is a placebo bit of this stuff, and it's important that they are on board in some capacity. And if they're like, this is horrible, I hate meds, but you said take them, so I'm taking them, it's going to be really hard moving forward. So, I would want to understand what they're hearing in their household, what they've heard from family, and kind of target the specific things, right? So if she said, well, my parents don't really think depression is real, they kind of think that I'm making this up, I would say, have you tried to talk to them about it and what it feels like for you and how you experience and how it affects your life? And if the answer is yes, I mean, there's also the not talking to your family about all of these things, especially as a 26-year-old. But if you're really trying to get them to understand and you really want to have those conversations, or they want to have them with me, it's a conversation around how depression is a real illness that has a basis in biology, and we know that, but it also is an interaction of psychosocial factors. So what's going on in your life and how you're processing things in your psyche, that it's treatable, that there are ways to help people be better. But just like having high blood pressure, sometimes it can have times where it's worse or better, and you might need to change medication, or you might need medication in the first place. And that doesn't mean it's a weakness or something's wrong with you. It's just like any other medical illness and needs a treatment. I try my best with things like that, especially when they come up. But I do think it's important to understand kind of what you're working with there and not just make assumptions, because there are lots of things that people might believe, and you might have to try to come up with a specifically targeted response. But I would also, as I do my college students, remind people that they're adults and making decisions about their own body and their own medication, and that while it would be wonderful for their parents to agree with everything, it might take time, and they need to treat themselves now, and time is not necessarily that easy to come by when you feel really bad. So I think sometimes you just have to start the treatment despite your family and have those conversations as they come, but it's hard.
How do you talk to somebody about like the initial treatment decision? Let's say you're able to convince this young woman that she should do something for treatment. Like, what does that conversation like, what does it sound like, if whether they want medication or non-medical therapies? What options do you present them initially?
Yeah, I mean, I think for me, whether I start meds right away versus whether I think somebody's fine with just psychotherapy is, again, sort of those same things. Like, how severe is it? How much is it impacting their life? And probably also, has this happened before? So if you've had an episode of depression, you took meds, you went off meds, you're going to need meds. Like, they helped before, this is your second time. You tried to go off, you might need to be on more long-term as a result. But I think that's part of it. Family, like if your family's been on meds before and it worked for your family, you might start meds earlier too in someone, just because there is some genetic correlations, and depression itself is genetic in some capacity. So having the ability to kind of think through that is important. But, what I would probably say is, based on what you're telling me and how much it's impacting your life, I think it would make a lot of sense to start a medication right now. I think a medicine makes a lot of sense given your symptoms and like what you want out of your life that you're not able to do right now. I think we would start with a selective serotonin reuptake inhibitor, because that is the most common place to start, but not always. That's another conversation that I know we're going to have a bit later. But I think the reason why I think meds would be helpful is I'm not sure that you are in a place to do this on your own, that like if you went to therapy, it might not be beneficial because you're not fully able to participate because you're so sad, because you're so tired. And so getting to a place where you feel better will even make therapy more effective. And so that's why I recommend meds. If you're opposed to meds, I can't force you to take medication. And so then we would have a conversation around like, well, why are you opposed? Is there anything I can kind of work through there? What have you heard about medicine that's scaring you? Because there's a lot of stuff online. And if you try to Google any med, especially by name, you'll find more of it. And so trying to break some of that down to help people understand, a lot of it is like they don't work anyway, or side effect related, or am I going to have to be on this for the rest of my life? And those are questions that they should ask you and you should be able to answer. And then if they still don't want meds, I usually make some sort of deal. Like, I hear what you're saying. You don't want medication. You don't feel ready for it yet. From my perspective, I'd still recommend it. And that's what I'm going to write down in your chart. But I'm also going to say that you decided to go to therapy first, and we decide together, like, what that looks like. Are you going to go a couple of times, and if you still feel really crummy, you're going to come right back? Are you going to come right back if you feel worse, which would be what I would recommend no matter what? So if you felt like your symptoms were worsening, or you had suicidal thoughts or anything like that, you should come right back and we should talk again about medication. A lot of times, and this is honestly the same with anxiety, it's like people are scared up front, but then they realize it's not going away, or they try the thing that they'd like to try. Like maybe that's exercise. Maybe that's going to therapy because they have friends that like it and have liked it. Maybe it worked for them before, and this just happens to be a worse time. Maybe it hasn't been that long that they've felt bad and they just don't see the point of being on meds yet, right? And so you have to sort of work with them in that capacity to get to a point where they'll call you if they feel worse, or they'll call you if the deal doesn't work out, like kind of bargain with them in some way there. Of course, that doesn't hold up if they're actively suicidal in the office or something like that, because then you're at a place where you have to do risk assessment and consider hospitalizing them. But if they're not at that point, if they're like this patient, it's a choice. That's their body and their decision, just like any medicine that you try to prescribe to someone. And so I try to make deals where I can to get them on my side and have them understand like therapy works, but sometimes you need other things, and that's okay. And what would that look like for you to come back to me when that happens, or if that happens?
I appreciate that. And I feel like the practicalities of things often will sometimes dictate whether you prescribe medication. But like, this is something I think about all the time. If your motivation is decreased and you're exhausted because you're not sleeping and life already feels complicated and terrible, then certainly therapy would be helpful, and certainly behavioral health specialist would be great for this person, but access is such a barrier. And if you ever called the number on the back of your insurance card, I'm not depressed, and when I call that number, it just sucks away any willpower that I actually have. Like, it's a grueling, confusing labyrinth that offers no real help. So I don't know that's an immediate answer that's going to be super satisfying if you especially feel like someone's in dire straits, and especially if you part of the symptomatology of that is a barrier to going through things like that, then that sometimes influences me to pull the trigger earlier on medications, but I'm not sure. That could just be self-justification too. There was no question in there, by the way.
I think everything takes time, right? So getting a therapist will take time, and medications are going to take time.
Right.
So if you follow studies, it's really 6 to 8 weeks. It's just nobody can do that in real life. Like that's not feasible in real life. So, meds are going to take a long time to work too. So both of the things will take time, which nobody really has when they feel bad, especially that bad. And so I think it's important to have that conversation too. Like, hey, I understand that you want to go to therapy first. Therapists are hard to find. Appointments are hard to get. If you call and you can't be seen for like months, can we talk about maybe starting a medicine in the interim? And, things like apps can sometimes get you in quicker, and that's fine, but usually it's a quality of care issue. And that's something to say. Like, if you want to go on one of those apps and get seen tomorrow, that's fine, but you might not think that that's a permanent fix. You might like the person for this week, next week until you get in, and that's okay too. And then, the same, like, by the way, also meds can take a really long time to work, and I don't want to wait and start this when you feel worse, because it could take so much longer and you already feel worse. And so I'd rather start now because it will take time. And so those are both conversations worth having with people, because I don't know that everybody understands the realities of the mental health system if you've never tried it. And you certainly don't understand why a medicine would take that long to work, because most of the time medicines don't take that long to work. Like if you're only used to antibiotics or inhalers, or I don't know, things that like maybe are common Advil or, like ibuprofen things, like those things work really quickly for the most part. And so I think that people don't think about time when they're thinking about this either.
We talked on an episode on bipolar disorder about asking questions, making sure that, what we really talked about is that the SSRIs, SNRIs don't necessarily work for bipolar depression. It's a different type of depression. And then you could also potentially precipitate mania or rapid cycling. So how do we make sure we're not going to accidentally prescribe SSRI to someone with bipolar disorder?
So they're 26. You're smack in there for sure, timing wise. So that's important. That's why I think when you think about this description that you should ask more questions just to make sure you didn't miss symptoms of mania at all, or hypomania, because it might be subtle and not like hospitalizable mania for somebody when they're younger the first few times. And so that's worth questioning, asking them about periods where they felt invincible, top of the world, did things that weren't their like typical behavior, uncharacteristic behaviors, risky behaviors, anything like that, to better kind of understand. Family history is important here too, right? So if your mom has bipolar, I'm going to be more concerned that you could have bipolar. It doesn't mean I might not try an SSRI. I might be much more likely to say, like, the second you notice anything weird, like, we're stopping it, versus sometimes people hear you say that as a risk and call because they didn't sleep, but it was just not sleeping, and it's not like, oh no, you have bipolar. And so I think it's always something you explain to people up front. Like, there's a chance that, you have undiagnosed bipolar disorder, and as a result, if I gave you this medicine and you feel like all of a sudden you're acting differently, or your partner says you're acting differently, or your kids do, like, that's something you need to tell me right away. And same thing with suicide risk. I think it's confusing to people that there's this like a black box warning on a med that helps with suicide and tells you could have more suicide. Most of the time that's in kids, and a lot of those studies are in kids, and that's important. But it's also just important to say, like, the risk is low, and this usually treats suicidality. But if you are right now not suicidal, and tomorrow or the next couple of weeks you are much more suicidal, or you start thinking about it, that's something we should consider. It's hard because it also could be symptoms worsening, right? Like, it can get kind of messy in there, but we probably would err on the side of caution for a lot of this stuff. Same with mania. Like, we'd probably err on the side of caution. But I would hate to jump to diagnosing bipolar depression in somebody and treating with more heavy duty stuff if you don't need to. Just because of family history or something, I wouldn't do it.
Yeah, Paul. I feel like I'm usually able to get a pretty good sense, and then I always try to keep in close contact with people when I'm starting them on antidepressants. But do you have any words of wisdom as America's PCP?
I think it's really important that you talk to them about what to look for, but don't scare them too much, because there is some suggestion on some of that. If you give them just every side effect and every possibility, it could get kind of scary in there. And you're probably already dealing with medication hesitancy. And I think that obviously you need to have an informed consent conversation of risks and benefits, but I kind of do it knowing the audience and try to make sure the main things get covered. And maybe I don't cover the thing I've seen in 1 to 3% of people, because it's not going to help them if they go home and they have that. That is something that they can tell me later. I think you can make people more anxious, especially if they hate meds to begin with, or really don't want to be on them to begin with. Always talk about the serious ones. That's the way it is. I think it is important to maintain contact with patients. I say you're not annoying me if you need to ask me a question. I think for some reason, people with depression, maybe because of what Paul was saying about motivation, it's a big lift to call, or it's a big lift to send a message. But then they're because of negative thoughts and self-esteem stuff, if you don't reply right away, or they feel annoying, they're going to be they hate me. They're going to be so mad that they wrote me. And so I'm really I'm hey, we're starting a new medicine. I want you to talk to me about it. It doesn't annoy me. I want your message. Please send me your message. I need to know what's going on. I need to help you. I can't do that if I'm guessing. So, be as open with me as possible about it. And I think that helps as much as it can be helpful for people, but it's still pretty person dependent, I think.
You're giving them permission.
Yeah, I think they need it. I don't know that every patient needs it, because I'm sure you guys are oh yeah, have you seen my inbox? But a lot of patients with motivation issues and self-esteem issues, and very quick to go that reply was mean, and with an email you could think about it with a friend. that's the patient who is going to have a hard time messaging you.
I don't know how this will go over, Matt, but I'm a big believer in the 2-week phone call check-in. I know people feel some kind of way about better an office visit when you get paid for work, blah, blah, blah. But I also think if you have a concrete plan that is relatively short term, that shows that you actually care enough just to reach out and make the phone call, it takes 5 minutes of your time, just to hear that the med's going okay or it's not. And I think you actually maybe head off some of those inbox messages, and it doesn't actually put the onus on the patient necessarily. I feel look, I'll call you in 2 weeks. This is the time I'll plan on calling you. I actually make a little notation in my calendar. I do this all the time just because I don't have access. It doesn't necessarily need a 20-minute visit. It's just a way to kind of check in, make the patient feel validated, and not make them feel additionally burdened when they're already feeling kind of run down as it is.
See, that's why you're the best, Paul.
Yeah, I would just say quickly on that, that sounds very kind. I think that when I'm starting people on meds, I typically say hey, you're more likely to have risks before you have efficacy. You're going to have side effects, right? Because they're going to come in the first 2 weeks probably, and you might not even know the med works at all, right? And so that's a very hard thing to balance at that time. And I warn about that up front. But sometimes I don't see people for a month because of scheduling and life, and they're fully able to function. It's just then I say call if you notice something,
So I want to wrap up this first case and get on to the second case. So what medicine might you start her on as just the first line? Do you have a favorite SSRI or 2 or 3 you choose from? And then anything else you would tell her to do?
Sure. I'm going to annoy people with this answer. So there's not a lot of studies of start this, then do this, then do this. There's one a long time ago that's famous. It's called the STAR-D trial. That's the one that if anybody's going to cite something, they'll cite. They use citalopram as the first antidepressant. Escitalopram is quite similar to citalopram. They're enantiomers. So, that's a truth. However, that's just what they chose to start start due to side effect profile. That's just what they chose to start in that study. It doesn't mean you have to start there. So, for me, because of her premenstrual dysphoric disorder, I might consider something more like sertraline, because there's a lot of evidence for that particular medication in all things women's health. I think that could be a good answer. I often consider things like side effect profiles when I'm thinking about stuff. I also think about what else is going on with the person. So if the person also has chronic pain, you might jump right to duloxetine, right? And that is okay. It's not according to STAR D, but that doesn't matter because you might go right to that. If a person's presentation is fatigue, overeating, sort of atypical depression, you might start with bupropion, despite sort of that not being in that study, and sometimes is not a first choice for people because it's just like hasn't been around as long, but it works really well for that side effect or that sort of symptom profile. So, you could consider things that way. I think it's hard to say this is exactly what to start with in this person, which is one of the things that's really frustrating about mental health medication, because it would be nice if we had more studies that did that, or we had a better way to know exactly what to give somebody. But, a lot of us just have favorites and then we go by side effects and then we go by other things going on in their life that it could be beneficial for and kind of go from there and hope that works. And sometimes I tell patients like the reasons why I picked a particular one, but that it might not be the right answer and we might have to try a different one, and that's okay. It's a little bit more of an art sometimes.
And when we talked about anxiety medications, starting them, I think you told us that, sometimes you'll tell them maybe they start on a slightly lower dose because some meds can be activating. With depression meds, like let's say sertraline, it comes in 25, 50, 100. Do you start them at 50 right off the bat with that one?
I probably would, especially if I wanted them to get better quicker. But I think there's always a risk that depression and anxiety are comorbid. And you could say, listen, if you notice like you feel more activated in that you feel more anxious or keyed up or you're not sleeping, like call me and we will cut it in half for a little bit first. If people have told me that they're sensitive to medications or tend to get a lot of side effects or have tried an antidepressant before and had side effects, I might baby it just to almost like mentally appease them, but it would be like 25 for a week. And if they're tolerating, we would go up. Like I'm not going to hang out at that for a really long time if I don't have to. I mean, I've had patients compound medication and because of like side effect needs, and that's a rough conversation to have and do, and it's also very expensive. So I try not to do that except for in extreme circumstances of people's sort of reactivity to meds and mental health symptoms as a result.
All right, so let's tie up this first case and say we started Miss Down on 50 milligrams of sertraline, and we followed up with her in 2 weeks, the Paul Williams method, and she had maybe a little headaches, but overall she got through it, and she's also maybe starting to see a therapist and starting to do some, let's say, just some walks, some brisk walking, which is making her feel better. And we'll leave the case there. And Zoya,
she likes a brisk walk.
It likes a brisk walk. It's nice. It's the springtime. Spring's on the way, and she's enjoying it. Zoya, let's go to our next case.
Yes, definitely. So our second patient is a bit different. This is Mrs. Kat Mean. She's a 54-year-old female, past medical history of major depressive disorder, obesity with a BMI of 34, chronic low back pain, and substance use. She has alcohol, one standard drink almost every day. Over the years, she tried escitalopram, fluoxetine, and venlafaxine, but never perceived much benefit. She started on sertraline around 1 year ago and has been on sertraline 150 milligrams for many months, where she had only mild depressive symptoms. But in the past 2 weeks, she had a change. Her depressive symptoms have been worsening. She can't think of anything different that might have been causing this low mood, but she's also having lack of energy, lack of interest, difficulty eating and sleeping. And she's also been having thoughts that she might be better off dead. But when you ask her more about these thoughts, she shares she doesn't have a plan, and she also starts to cry and wants you to know that she's not serious about this. She lives alone. Her husband passed away 2 years ago, but her 3 adult children live nearby. She feels generally supported and works as a part-time substitute teacher. So again, a lot going on, but what would be some of your initial recommendations for our patient?
Yeah, I mean, first of all, I would do a bigger risk assessment because it just sounds not great either way. Like, I would want to make sure I understood how safe she was. I think that it might include permission to call a kid and talk to the kid about her and let the kid know that she's struggling, and maybe she wouldn't live alone for a little while she was like trying to get treated and feel better. I don't feel super great about being like, bye, go home by yourself. That'll be fun. You know, like if you have the option and nearby children, my gut says that like you want to get the kids involved and you want her to not be alone for a little while we figure this out. You might not have to hospitalize her, you know, like that's not always the best choice for people, but you just want to make sure that you're helping them be as safe as possible. And that I think is important. You know, I think because she's tried medication before, this would be her 4th, I believe. And she's been on that one for a long time. You're going to want to refer to a psychiatrist. You know, I mean, I think it's going to feel frustrating because you are going to want to do something. And I'm not saying that you can't do something, but I do think that this is way outside the realm of what a primary care doctor should be doing. And I hope that even just hearing this case, every single person thought that too. You know, I think that my opinion is like, of course, there are places where there are no psychiatrists and it's easier said than done. And you might have to still see a person like this. But I would hope that after one, maybe 2, I guess, probably like failed trials of medications, you'd be like, I think you could see a psychiatrist. Part of that is time. Part of that is this is literally our job. And so we should see those people. And I just don't think that like a patient like this should be on your caseload given a choice. But of course, you're not going to be able to get them in like tomorrow unless you have a psychiatrist like embedded in your clinic and you can go get them and have them help. So probably what I would also want to know is failed trials are failed trials in people's head. Did you actually have a full trial? Meaning, did you get to a really good dose of the medicine or did you only take 25 of something, right? Like that's not a trial. And that's important to know because when we're thinking about like what works or what you could try again, you want to make sure that like they actually failed it. You also want to know if they stopped for side effects because that's also another reason, right? Like then it's a little bit of a different reason, like the medicine didn't fail, they had side effects to the medicine. So I think that that's also important to figure out. Sometimes patients don't know and you might have to like kind of guess and try to get them to remember. And that could be hard, but that's important in this. I think this is her 3rd SSRI. So to me, you probably would either add something or switch if you're going to make a decision in the office for the patient that's going to be medication based, because it doesn't seem like it's working. And if you look at her history, it doesn't seem like they've worked, period. So probably SSRIs are kind of off the table and being effective for her. But you also could say, it worked at one point and it started working initially, then you went up and then it stopped working and like after a while. And if it had like a little bit of effect, you might add like something as an adjunct instead. And that's just because it might boost that existing med. So that could be anything from bupropion to Abilify. And I think we might add an adjunct in that situation also, because you don't have to switch and get her off of a med to put her on another one, or you don't have to taper down and taper up, which is really hard when somebody's really feeling crummy.
Okay, so in a patient like this, it sounds like you're thinking if they have a partial response, you might do augmentation with like a antipsychotic or bupropion you mentioned. We have a listener question that I actually wanted to play for you, and it actually pertains to, let's say that this was actually their first SSRI, and you were thinking maybe you were going to just switch them to something else. So let me play this question for you.
Hi, this is Deb White. I am a family nurse practitioner in primary care in Mesa, Arizona. Have a question for your upcoming antidepressant program, and just more so on, why you would switch from one SSRI to another, or even more so tapering between classes. If I'm switching from an SSRI to an SNRI or to an atypical, what's the recommended practice for tapering? Thank you very much. I really enjoy listening to the show.
Okay.
3 cheers for Deb. Thanks, Deb.
Yeah, this is a good question. So if you take one SSRI and it doesn't work, it doesn't mean that none of them will work, which is important, I think. They're all slightly different, which in enough of a psychopharm sense that it doesn't rule out an entire class simply because one didn't work. And so often we try another one. So it's not like we're just throwing the same thing back at you. We're actually trying something else. If you had a little bit of a response and it was imperfect, we also might try a similar one for that reason, because it seemed like maybe it would work and that's useful. We might switch classes for lots of reasons, including failing a bunch of them, or you're a person who doesn't like to try a bunch of the same class of medicine, so we try something else, or you have chronic pain or some of these other things we talked about, which might lead you to an SNRI. They are different in the neurotransmitters that they work on. So sometimes like maybe you need more than serotonin, and that's fair and true. And when you switch between classes or between meds, it's imperfect too. So you can have withdrawal from medication. There are some that are worse than others. Venlafaxine, bad at coming off of. It's just real hard to come off of. People feel really crummy. Paroxetine, also really hard to come off of. As a result, before I put people on those medicines, I tell them that. And if I know that a person has had bad withdrawal from something else, I might be hesitant to put them on either of those as a result, because they're very likely to have a crummy time coming off of it. When I say crummy time coming off of it, it can feel like flu-like symptoms, like that's pretty common. But you also can get this thing that's called brain zaps, which is like how a patient describes it, and it exactly feels like that. Like you feel like there's an electric current coming from your head and comes when you don't expect it. That's not fun. Nobody wants to feel like that. It should go away, but if it's all really common, that's going to make people taper you slower, or just like, stop tapering for a second. I'm a big fan of the crossover for that reason. I don't think it's really helpful to like stop one to start one unless you had like a big allergic reaction to it, or you needed to stop it for side effects and you wanted to stop it right away. But if you like are trying to taper one down, or like in order to start another one, it's better to sort of go up on one and down on the other, because I think it makes the withdrawal a little bit better, because you're kind of like putting it back in to your system by cross tapering it. It also makes it go faster. So I said meds take a long time to work. If you were like, okay, I'm going to get off this med and then I'm going to get on another, you might be like you're going to take weeks to have that happen. And that's pretty hard, given that the meds already take weeks and you have no idea if what you're switching to is going to work or be better, which is not fun. When I think about tapering, on average, I go down about every 2 weeks, probably every 2 weeks. The evidence is mixed on this. Some people are really challenging to get off meds and could take like a year. But for the most part, people can come off of it very fine, with kind of going stepwise down every 2 weeks. I usually say to people, like, at 2 weeks, are you done with those withdrawal symptoms and do you feel okay? If so, we will keep going. If not, we might hang out a little longer just to make sure that you don't like have withdrawal perpetually and it doesn't make you miserable.
So are you saying if this woman that's on sertraline 150, maybe you go down to 100 for 2 weeks, and would you start, if you were going to start her on another agent, venlafaxine or something, would she start taking that while she's still on the other agent?
Yeah, sorry. That's what I meant by cross tapering.
Yeah.
So if you're on 150, you would probably start at 37.5 of venlafaxine due to, again, the fun and exciting nature of going on some of those meds versus other ones. So you would go like, I'm at 150, I'm going to drop to 100. When I drop to 100, I will also start 37.5. I will do that for 2 weeks, both of those things. And then if I'm okay and don't feel bad, I will continue to go down and I'll go down to 50 and then I'll go up to 75, right? So it's like you're crossing over.
Yeah.
Then assuming that like all's well, I'm probably not going to make you also go down to 25. If you're having a hard time, I might make you go down to 25 before you come off of it, just to like make sure it's getting out of your system. If you feel fine, we'll just stop that. And then we'll kind of see where you're at with the 75. And if you feel like it's maybe working a little, we'll probably go up on that too. Mm-hmm. Does that make sense?
Yes. Can I ask, if you're, so you, all the way back to the beginning of that excellent explanation, you said that there's sometimes utility in switching even within class. And I'm just wondering, do you cluster the SSRIs together in certain ways? Like, do you group them together? So if you have partial efficacy with one, does that affect what your backup plan is for two, or is that based mostly on side effect profile? I guess what goes into your calculus when deciding to actually switch within the class before you actually switch to a different one?
It might be side effect profile. So sometimes certain meds make people hungrier. Some meds make people more tired. If you're having those like side effects and that's the reason you don't want to be on them, like you can't even tolerate going up to a high enough dose because you're just like, I'm tired all the time, make this stop. And even if I move the med to nighttime, you're like, I'm tired all the time, make this stop. Then I would probably try something else that I know is not as fatiguing. So, I think that again could end up being a different class, right? But it also could be fluoxetine can be less fatiguing as a medicine too for folks. So you might switch for those reasons, like just based on what they say the side effects are. And if it's bugging them, again, for fatigue, move it to nighttime before you take them off of it completely, because it's, again, these meds are really hard to know if someone should take them in the day and nighttime. And you kind of have to see how someone responds, except for something like bupropion or fluoxetine. Both of those, I think, are morning meds. The other thing that might make me pick one or another would be the same citalopram, escitalopram thing, or venlafaxine, desvenlafaxine, right? So if you did have some response and it was like partial, or it worked for a really long time and then it stopped working, because that does happen, I might choose the one that is very chemically similar in hopes that it also worked just as well as the other. That's what I do. I don't think I've read a million papers that say to do that or anything, but I do think it has worked for patients doing something like that, especially if they really liked escitalopram and they maxed it out and it's been years and it stopped working. Then, you might say, well, there's this one that's similar. Do you want to try that? And sometimes that can help.
Let's get back to the initial scenario where she's on her fourth, SSRI. Well, was it her third or fourth SSRI, and she's also tried an SNRI, and we're trying to decide, what might be the next step for her to try to get her feel better if you're going to do something with medication. You mentioned augmenting. What might that look like?
Yeah, again, it depends on if it's like partial response versus no response, and also what dose they're at. We are really not good at maxing out meds. People
Yeah.
get really frustrated at meds really quickly and they do not max them out. Again, why I said that about trials is like people go, I hate this at like 100, but the max is 200. So how do you actually know that you hate it? You hate it because it didn't work fast enough. You don't hate it for side effects, you know? So I think we just have to be mindful that that's the case. I think that I retry meds in people because of that. Like if it was pretty clear that they didn't have side effects, but they don't remember if it worked or if they got to a higher dose of it or not, like I might retry something, especially in those people where you look at their list and it's like 50 and you're like, how did you get here? But I would usually start with, if I'm going to augment something, I would probably start with bupropion or aripiprazole, because both have good evidence as augmenters in depression, especially like this is qualifies as treatment resistant depression because she failed to we're assuming adequate trials of at least two of those medicines.
Right.
You know, again, the adequate trial part is hard, but you know, medications only work in like about 2/3. There's always like a group that it doesn't work in, and that's important too. But you know, as a primary care doctor who doesn't have access to a lot of other things, and even as I'm basically a primary care psychiatrist, like I'm not doing any of these alternative things in my clinic. So if I needed that or thought that made sense, I would refer to somebody who could do other things for them besides medication. But what I would feel like my tools allowed and what you will feel like your tools allow is to keep trying some with.
And you mentioned the maxing out doses. I'll confess, as a primary care doctor, I'm usually not maxing out doses of like SSRIs, SNRIs, or certainly not multiple agents. And that's probably I'm probably not being aggressive enough. I don't know, Paul. Do you feel the same, or do you?
Yeah, no, it's. I think it's easy to inertia, especially if someone endorses partial improvement. Like, no, I think I'm better. I'm like, all right, we did it, success. You know, doing a victory lap, and I don't know that we've actually sort of maximized the efficacy of the medication or actually gotten them as good as they could be. But I think sometimes I'm just happy that we're better as opposed to as good as we could be, and probably just stop. So yes, I feel that.
In my experience, it's also patient dependent, right? Like I can write a paper, I can read papers and do studies where they say people can wait 6 to 8 weeks on one dose of a medicine. But if you have a person in your office, they're not waiting 6 to 8 weeks. It's why even inpatient psychiatry, you'll notice people pump meds so much quicker, and it makes no sense based on literature, but it's just what they do in those settings. And so I think it's also important to recognize that some of the drive to switch and the drive to increase or, you know, whatever is coming from patients because they feel uncomfortable and unhappy and it's taking too long. And so you might be doing some stuff to appease them, and inherently that's okay, but I think recognizing it is important too. Like, hey, it would be great if I could keep you on this for 6 to 8 weeks like the literature says. However, it's very unlikely, so let's try increasing again, you know, and that's okay. It's just important to recognize like where that drive is coming from, and sometimes it's coming from inside the house.
Let's ask about genetic testing, because this comes up, this pharmacogenomic testing. I read about it as I was preparing for this, and there at one point they basically mention it's available, and then they mention, but it probably doesn't change much of what we do. But I'm just curious, like in your hands, is it affecting care, and do you think it's helpful?
Yeah, so I wanted to talk about this because it comes up a lot. It's one of those things that feels like it should be a good answer, and it often isn't. The real issue is it's not covered by insurance. That's issue number one. So it's going to be expensive. Issue number two is their correlations, not causations. So just because they think you have some genetic marker that maybe suggests you don't metabolize one as well, or one might not work as well, they're guessing. Like, it's not perfect. We're nowhere near precision medicine where you could say, well, because you have this gene, you should absolutely start with this med, and then if that doesn't work, you go to this med. We're not there yet, but I will tell you the patients I choose to use it in. The most anxious of them all. So if patients are very side effect anxious, like, or they've had some meds and they've got and had a good amount of side effects on them, like this patient came in and all of the reasons that they stopped all of those was not because they were ineffective, but because of side effects, I would tell them to get genetic testing, and I would use it as a guide with caveats. Like, hey, let's do this. It's a correlation, not a causation, but it might make you feel better to know that I picked the meds in the green zone instead of the meds in the red zone. So like, let's just try that. And it can be helpful for the folks that want to be working in a more evidence-based way. Like they want it to help, and in a lot of ways it's psychological at that point. But I've had it be successful for people at sort of toning down their anxiety around side effects, or, making them feel like I'm not just throwing darts. Cause sometimes it can feel like we're just throwing darts, like, oh, let's try again. Oh, that didn't work. Let's try something else. And so, like that's really frustrating. And I get it. Like I wish that the genetic testing was so good that we all got it. It was covered. It worked. We could start with a particular med. I'm hopeful that's like the future of psychiatry, and someday it's just not there yet. But, for some people, it can be really kind to do something like that, with the caveat that it's not like perfect, because if they think it's perfect and you run out of the ones in the green, you are going to have to go to the yellow or the red. They're done by stoplight colors, and you're going to have to explain to them why now you're not listening to the colors, right? So you don't want to like overpromise, but it can be a good place to start, because it's true. I will say sometimes too, like the meds that they suggest sometimes are the expensive ones. And I don't love that either. Like, why is the med that seems to work for everybody still on patent? But I'm not judging the genetic test company in that, but it does feel suspicious.
Because they sound innocent.
It feels suspicious to me that it's always like that the older drugs are not the ones that are like regularly popping up there. But again, that's an assumption from my soul.
Speaking of, because you mentioned some of the newer drugs, we had another listener question that I just wanted to play.
Hi, I'm calling with a question regarding treatment of depression. I'm wondering what the role of vilazodone or vortioxetine is in management of depression. Is there a benefit over SSRIs or trazodone? When do you opt to use these medications? Thanks.
So those are drugs that I guess I'm aware of, but I've never prescribed them. So I'm curious.
Newer meds always have a little bit of something different, So I think that it's never like if you feel like you've tried a good amount of SSRIs and a good amount of SNRIs, like sometimes you go either to older classes, like we might go to tricyclics at that point. Mm-hmm. They're not your first choice often because of like the cardiac and sort of prolonged QT risk, which is higher than an SSRI, but it doesn't mean they're bad. We just don't start there, right? And so you might kind of throw back to that, or you might go new med and try something else. And that would be, a med like vortioxetine. In my opinion, like I've used it and I've seen it work, but it's not my first choice just because of cost ultimately. I wish we had more head-to-head studies in comparing, but we just don't have a lot of like, we gave this number of patients this and this number of patients this, and we watched, and this one was better by this much. We don't have a lot of those studies, which is unfortunate in the sort of question of, is it better? But, most of the time we're picking based on things like they've been around longer, so we have more evidence of their efficacy, side effect profile, and then sort of like, cost. I think something like that could cost a lot, even with insurance coverage, at least in my experience of trying to order it for a patient.
What about trazodone for depression? We didn't really talk about that one. I think a lot of internists are sort of like low-key using it as a sleep med at like 25, 50, 100 milligrams. But it looked like the doses used for depression might be higher than that. So is that something that's that you use, or do you use it augment?
I've never used it for depression. I think that's because I think that it was one of those meds where they invented it for one reason and then it made everybody sleepy. And so it was a sleep med, right? And so I think that at higher doses, you're going to zonk people out. Like, I don't really know how you're going to not have them tired. Something like mirtazapine would be better if you're having like some trouble sleeping, but also trying to figure out like what to work for somebody. Because then you could have antidepressant effects and sleep effects, but keeping in mind sometimes people eat everything on mirtazapine. The weird thing about mirtazapine, if people remember from boards, is that lower doses are more sedating and higher doses are more antidepressant. So you might start at the mid dose instead of the lowest dose for that, because you don't want to like assume one or the other. And then if they're like, oh, I'm way too, like, I need to still sleep, you might actually put it down. And if they're like, this isn't working as an antidepressant, you might put it up. So that's a weird med like that. But it's great in older people, and it's great in people who have 75 meds to begin with, because it doesn't have a lot of medication interactions. It's like the go-to consult med for people because of that. But I would go there for a sleeper, like if it needed antidepressant effects, more than I would go to trazodone. I tend to use trazodone as just a sleeper med, and like maybe that's my own bias, but that's how I've used it.
Okay. So Paul, how often are you referring people for TMS?
That's happened. Let me think for a second. None. I've never done that. Not once. But it's probably something I should be doing more frequently, it sounds like.
So it's I believe it stands for transcranial magnetic stimulation. And Jessi, are people doing this in the community? I mean, it seems to actually have some evidence. And there was we can link to it in the show notes. It was the British Medical Journal had it was a new and emerging therapies article that was kind of talking about this and some of the other things we're going to get into here. So what are your thoughts?
Yeah, I mean, transcranial magnetic stimulation, always called TMS because what a mouthful, is actually quite effective. Right now to be covered by insurance, you have to be considered treatment resistant, meaning you failed to. I think there's a lot of arguments around whether we could be pushing that some, and maybe it's one failure and then you'd go to it because it has a lot of efficacy and it does help with like people who are pretty severe. You go in every day. So I think that can be frustrating to people because you're like, you have to go in every day for treatment for like a couple weeks or whatever, and you won't see something right away. It's one of these things that it's like, you're there and then all of a sudden it works really, really well, but it's a short amount of time when you go. Usually it's like 10 to 15 minutes or like an hour at most of the time. So that's also weird for people because you're just like going into the office, going and like having this done and then like leaving regularly, and you're there all the time and you know people. But Nolan Williams at Stanford does a thing like a whole profile, like a whole protocol that's really cool and quick and has a lot of evidence and is, really one of those things that's going to get around to everybody if it hasn't already. And so I think
he does the accelerated, right?
He does, yeah, rapid TMS, yeah, exactly. And it's called like Saint, and one of the S I think is Stanford, and then I forget what the rest of the word means, but it's Saint, and he will probably hate me for not remembering because he's my attending and taught me TMS like 14 times, but we should be referring to it earlier. I think one of the other benefits of it versus something like electroconvulsive therapy, which also has a ton of evidence and has been around a really long time, but has a ton of evidence despite One Flew Over the Cuckoo's Nest scaring everybody from it, even to this day. It doesn't have that like retrograde amnesia bit that you get with, or you could get with electroconvulsive therapy. So sometimes people remember being on a psych rotation, having people get that, and then they don't remember like what happened right before, or they don't remember like some time period. That's freaky for people. Like people don't love that. You also don't need to go under anesthesia. So that's a plus too. Like it's in an in-office procedure, which is really nice. And I think people like that as well. So both of those benefits over like sort of an older therapy as a result. And the only risk is really seizures, and the risk is about equivalent to the risk for bupropion. So if you're not worried as much about seizures there, you won't be worried in that, and in fact, if you do seize, you're in an office with people who can stop it immediately versus at home with a medicine where you can't,
Mm-hmm. Yeah, and from what I read, like the most common side effects are scalp irritation or headaches. So, That sounds like if it's going to cure your depression or fix your depression, it sounds like a small price to pay.
Yeah, I think it's good for people who have been side effect sensitive for the most part too. I think it's had some effects there. I think people have liked it. I don't do it in my office, but people have offices that do. Mm-hmm. And so you would probably just need to know like who in your neighborhood is doing that to have them be evaluated to see if it's a choice. Patients might bring it in to you because they read about it or saw like a CBS video on it or something and they're curious, or they are just frustrated with pure and simple medication and waiting and all that stuff. And that's fair. Like, I think that some of this stuff comes up when people go Googling because they're frustrated, and I would too. And I get it. So.
Well, Zoya, let's get to the last part of the case, and we have a couple other things to ask.
Yeah, well, I think Miss Katmeen has been doing exactly what you just talked about. She's been Googling about other things that are available for her, but she is coming back as a follow-up, and her PHQ-9 is actually a 21. So she's still having severe depression. And as we kind of discussed, she's failed multiple trials of antidepressants and has been reading on Google about alternative treatment options like ketamine, ECT, and psilocybin. So she's wondering if you've heard of these and what your thoughts are on any of these treatment options.
So again, like her worsening and living alone is earning her a significant look at the suicidality that's making that a 21. She might get inpatient electroconvulsive therapy depending on what's going on, because that's going to be the most effective for quick, like severe treatment resistant depression, especially when you want it to be done pretty quickly. It is very effective at remission, like up to 75% in older adults. And I've seen people miraculously in hospital go from like just never wanting to get out of bed to feeling really good. So I'm a big fan of it as an option. We probably don't use it enough from an outpatient to inpatient setting. Like, we're not thinking about making people go into the hospital for that, or, having it get set up as an outpatient. And so I think that should be in your mind, especially because of how severe it is. It is really good for severe suicidality and for people with psychotic depression and people with catatonia. All of those things, electroconvulsive therapies are really like early line defense for something like that. Things like ketamine and psilocybin are newer. There's a intranasal ketamine that's approved, but it's costly and you have to be watched while you do it because you can dissociate, like it's lower doses than Special K, but it's still that. So we can have it either, some studies it's intravenous, some studies it's the nasal spray. I think that it has been shown to work, especially again, sort of acute suicidality in folks. And so like that can be helpful. The dissociation part can be more complicated. The cost could be more complicated for people. And so sometimes that is not necessarily chosen for that reason. I would say like that transcranial magnetic stimulation probably has more long-lasting effects than something like ketamine, but we sometimes can get, if you can get ketamine intravenously or intranasally faster, you might feel better faster, and then you can kind of like figure it out from there. It's a acute suicidality intervention in that sense. So is lithium, by the way. Lithium has you can use it for suicidality, and there are not a lot of meds like that. It's like literally a reason to use it. It's an approved use. So that's often probably not used as much either, like because you're scared of like livers and kidneys and like just like everything that you're scared of with lithium side effects. But it also is good for that stuff. But psilocybin, also known as like shrooms, magic mushrooms. I've had a lot of patients try on their own, like listen to certain podcasters say they microdose, try to follow the rules, come in and are just totally psychotic, and it can last for a long time. It is not something you should do by yourself, number one. Number two, it's not really approved yet. It's still very much like an experimental treatment. And if you look at those studies, it's very hard to tell if the thing that's working is the drug or the therapy, because they go in and they basically get walked through a trip with a therapist. So they're like having a trip, they're going through therapy. It's very manualized. They have these like specific things that they do. And so nobody's just given it like, or really proven that just giving it alone is enough. And so I think that's also interesting, because it's like, well, is the psilocybin the thing that works, or is it the therapy? And I think that's important when you're kind of looking at this stuff.
Yeah, and the things that make me laugh about the studies too is just the placebo-controlled part. It just has to be a challenge. Like I know that like feed someone Benadryl, and you're like, this could be psilocybin, and they're like, yeah, I'm sleepy. So probably not. So like I have a feeling like it's going to be hard to get. Yeah, it's going to be a perpetually hard thing to study, probably, at least in the short.
Yeah, and those kind of drugs are really hard to study, period, right? Because of their schedule and your access to it. And so good clinical trials and even good small trials are going to be hard, especially in this country, to get passed through because of access to the medicine. And so we have some promise of psychedelics and stuff, but it's pretty hard to be able to do those trials and do them well enough. And often they're pharmaceutically funded, which I think people also sometimes have problems with when they see, but some of that is literally because it's so hard to get access to the medicine that's who can. But ultimately, I would say, you know, when you're kind of looking at this stuff, it's like what is available in your community. Maybe as a primary care doctor, it's helpful to know like, oh, there's a guy up the street who does, you know, transcranial magnetic stimulation and ketamine. And if I'm concerned about a patient and like need to get them in quickly or need to get them in for something other than meds, this person's good and we're going to refer and they're going to evaluate, right? Like you're not going to evaluate them for transcranial magnetic stimulation. That's so far outside your realm, but understanding like who's in your neighborhood and who does that. There might also be like a psychiatrist who loves a treatment resistant patient, you know, and also obviously kind of understanding like, okay, this feels like maybe somebody should get evaluated in an emergency room just because it's feeling a little unsafe and you're a primary care doctor and you don't want, you know, letting the psychiatrist in the emergency room decide that might feel safer sometimes too. And so, you know, I think that all kind of factors into the conversation here.
And I think I know the answer, which is one of the reasons why I wanted to ask you this, because you talk so lucidly about cannabis for anxiety on our last episode together. And I know this is not one of the more common sort of quote unquote indications. Usually I do see people talk about it for anxiety or for insomnia, but I do have patients ask about, you know, what about medical marijuana for depression? So I'm not sure if that's a question you get asked a lot, but I would love to hear your answer or response, at least in terms of how to think about the use of cannabis with someone who has depression, just because it's such a common scenario.
Sure. I think that more often than not, I have a depressed patient who's also using cannabis, and we have to have conversations about how they're mutually not beneficial, right? So ever seen a movie where there's a stoner, that person is not motivated, eating all the time, kind of looks depressed, but he's certainly not like having a great like day-to-day, like all the time feeling good, right? It's a different feeling good. I think concentration is not great when you're stoned. So I think all of these symptoms of depression can look worse in somebody who's like using marijuana regularly. I've had to have conversations about either decreasing amount while we're trying an antidepressant, not because like we necessarily know how they interact, because just like any sort of natural product, we don't have a lot of studies of interactions. But I do know that if I'm trying a med and you're still smoking every day, like I'm not sure that I'm going to fix your motivation, and I'm not sure that I'm going to fix your mood, and I'm not sure that I'm going to do very much. And so we often like, I'm a bargainer, a negotiator. So like we might try to decrease. We might use the same strain the whole time, right? Like go to the same place, get the same thing, stop messing with stuff, at least keep that variable the same. If people don't get better on meds, I sometimes say, so now that you're still smoking every day and you aren't better on a med, like, are we at a point where we could consider like trying this again to see what the impact of that is on your mood? I think people just don't recognize that it affects them in that way, like in motivation and concentration and sort of sleep and stuff like that. And so like sometimes it's pointing it out, sometimes it's like helping. But I do think for me, I would never prescribe it for depression because it's much more likely to cause symptoms that mimic depression or worsen depression. Because if you're sad and you don't want to do anything, and then you smoke pot and you definitely don't want to do anything, like that's not helping.
That's right. Thank you.
I think we should start to wrap up here. And I think one of the questions that we should get to is like, so for our first patient, we had started her on an SSRI. And then for this patient who's been on multiple agents, you sort of alluded to the fact that probably she's going to need medicine long term. For the first patient who was less complicated, it was let's say it was her first episode of depression. How do you talk to that patient about when can you stop meds, and how do you talk to the patient that's more like a treatment resistant or recurrent depression about medication?
Yeah, I mean, so especially that person that was the first patient who comes from a family that doesn't like meds, they're not going to want to be on meds forever anyway. Like they want to make sure before they start them that they didn't agree to now be on something permanently. And I think that's fair. Because it's scary to think that you are having a bad time and you take something and then you're stuck on it forever, right? Like that doesn't feel good. So usually I say 6 months and we'll see where we are. And at 6 months, if you've been good for a long time, we haven't messed with the dose in a long time, and you're feeling like you want to start trying to taper and see how you feel with the awareness that meds like to trick you and make you more anxious or more sad while you're coming down off of them. We could do that, and like that, especially because it's the first episode, like we could definitely and should definitely try it, honestly. Like I do think people probably get put on meds in college during a time that's hard for lots of reasons and then never taken off of them because there's no good time, right? Like I'll meet with college patients, they'll be like seniors and they're like, I'm great, like let's come off of it. And I'm like, well, you're graduating and then you're getting a new job and then you're moving, like, there's no good time, right? And so you're kind of like, you kind of have to try it depending on, like, you can't wait for a perfect time,
Mm-hmm.
like you can't be like, this is the time where my life is great, let's go off meds. I think it's just sort of like you want to try to come off meds, and so you try to come off meds, but that would be the conversation, 6 months, and then I would try. The other person, I would be like, I understand that meds are really frustrating because you've tried some and they haven't worked, and I would be frustrated too. I think that hopefully we will get you somewhere where you will feel like what you're doing helps, and that will likely include being on a medication. And because this has been a chronic problem for you, because you have tried multiple things, coming off and on is unhelpful and will make you worse, and will have periods where you will feel worse, and I don't want that to be true for you. And so I would recommend that you stay on it perpetually. I think it's possible that if you used one of the alternative therapies, you could come off of meds and be doing TMS maintenance or ECT maintenance, or, when they figure out what ketamine maintenance is. Like none of those like alternative treatments are like one and done, really. Like if somebody's really depressed to the point that they need that, all of the evidence is like they're going to have to come back, and they're still working on exactly what that looks like protocol wise. But sometimes, like, and there are studies like this, like if you do these type of treatments, you could get off meds and just be doing those type of treatments. And so that's always possible too. Like it's not like you're doomed to be on meds that you think are ineffective, but you could have just needed a jump start, and then the med was more effective in the context of not having like a high severe depression and being more mild, and it's just kind of keeping you at bay, which is also true. That's a long answer.
Well, I mean, it wasn't an easy question, so I think it was as long as it needed to be. Zoya, do you want to take us home and with the closing? And
can I say one thing? I actually think that what you're also at risk of a patient is like, I'm better, so I stopped med.
Yeah.
And I think that that's important for people to discuss and talk with patients about, because you could be better because of the med, right? And so when you're trying to have people come off meds, or you're talking about coming off meds, you have to recognize that there's a desire to just be like, I'm all good now, take me off of it, and completely forget that like the med made you better and the med might be keeping you better. And so like, I'm just putting that out there because especially folks who come from families or have their own hesitation about being on meds or being on meds forever or want to be more natural, whatever, they're going to be like, I'm cured, so I stopped it. Or like, I was due for a refill and I figured I'm better, so I just didn't pick it up, right? Like, it happens a lot. And that is a conversation you might have to have. So sorry for adding that, but I think that I see it way too often to not mention that. And I think that you'll probably have to have that conversation as a primary care doctor, even for a person with a first med.
Yeah. So thank you so much for adding that and also just joining us for this conversation. We've talked a ton about the different aspects of depression from medical versus psychiatric components, just explaining depression, how to choose antidepressants, and then also how to augment the regimens. But what would be some of your main take-home points for our listeners?
So first of all, thank you for being the first line of defense for most people with depression. Screen, that's important because you are the first line of defense. Most people who die by suicide saw their primary care doctor more recently than anybody else. And so that's why it's recommended that you screen. So thank you for that, being a first line and screening. Second, refer and don't just like try to manage these complicated people on your own. Like try to stay within your comfort zone and refer where you need to. I'm never going to be super mad at referring too early, especially if I have space. Like I like a person who's only been on one med, so send them my way. They're more fun than only having treatment resistant folks. But, I get it. And if you don't have access to it, it's hard. And then, when picking a medicine or picking some of these alternative treatments, just recognize that some of it's based on side effects, some of it's based on your own experience, some of it's based on what else is going on with them, and some of it's based on how many meds they've tried and not worked. And that's important too, and to consider some of these other things like TMS when you are referring people, because it is an option, and sometimes medication can feel frustrating and like it's too much, and that's okay.
And then something else we always like to ask, is there anything you'd like to plug? It could be a good resource on the topic or something else, or maybe even your new book.
Sure. So resource-wise, I would absolutely always tell your patients to be careful with what they find online about mental health, but especially things related to SSRIs and coming off of them. There is so much hate around that on social and on websites and on Reddit. And so just like tell them to bring that back to you, but give them websites like the American Psychiatric or American Psychological Association to look up things that are made for patients and families. Give them NAMI's website, give them the American Foundation for Suicide Prevention, like good organizations that have been around a long time and have good information, point them in that direction. As for me, I wrote a book that I am excited about, and it's about like my own mental health and healthcare worker mental health and, the challenges caring for yourself when you care for others. And it's called How Do You Feel? And I would appreciate people reading that if it feels of interest or to kind of understand what it's like to do jobs like this.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Nope, nothing, Paul.
No, I was just going to sit in it. I can wait around. Someone doesn't teach medical students enough. If we would have sat long enough, she would have said it. Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge, and we want your feedback, so email us at askcurbsiders@gmail.com. Reminder that this and most episodes are available for CME credit for all health professionals through VCU at curbsiders.vcuhealth.org. Special thanks to our writer and producer for this episode, Zoya Sarani, and to our whole Curbsiders team. Our technical production is done by PodPaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chu-Manchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
This has been Zoya Sarani.
And as always, our main Dr. Paul Nelson Williams. Thank you and goodbye.